Everybody perceives this concept of andropause as being a normal effect of the aging process in the United States, and that's really not true.
Podcasting from the base of Lake Tahoe in the eastern Sierras comes the Medicine Wheel. We are a group of progressive physicians seeking solutions and enlightenment while surfing the seas of big data and summiting mountains of research in an effort to make the practice of medicine more personal and medical knowledge more accessible, and empower you, the listener, to be as healthy as possible. Now, the Medicine Wheel.
Welcome everyone back to the Medicine Wheel. Today I'm happy and proud to introduce a good friend of mine and a colleague, Dr. James Raniolo, also called Dr. Jamie. He's a wonderful fellow I met about 10 years ago while doing concierge medicine in Vail, Colorado. Thank you so much for coming here, Jamie.
Oh, thank you, Sean. It's great to be here. I've been looking forward to doing this for a while.
Great. Well, I know that we had hit you up a few months ago to come on in, and you took the opportunity to come out of Jackson Hole, Wyoming. You flew down. We spent the holiday weekend together, which was fantastic. And now we'd like to take some time to learn a bit about what you're doing in the field of functional medicine, functional genetics. And specifically today, I wanted to talk to you about andropause and hypogonadism. But before we dive into that, I'd like to hear a little bit about how you even got involved in medicine, and for that matter, functional medicine.
Man, I guess my career has been a little different than most people. I never really wanted to fill that traditional role as a physician. I mostly wanted to go and travel and see the world. So I went out and I got a background in family practice as one of the most broad spectrum kind of backgrounds that you can get into to kind of do a little bit of everything, and spent the first bunch of years of my life traveling around the world. Wanted to find out how many adventures I can get into. So I took the strangest, weirdest jobs all over the planet, and in that regard, I became a prison physician working in maximum security prisons within Florida. I did urgent care centers all over Florida and all over the U.S. I worked for the Bureau of Indian Health and went down to the bottom of the Grand Canyon, became a subcontractor for the Department of Defense, and I used to work in the Kwajalein Atoll in Micronesia, providing emergency medicine services for some of the people who live out there, and just started traveling around the whole world and trying to figure out, what I can learn about medicine. And unbeknownst to me, what really started out as a desire for, I guess, a little hedonism and travel ended up being profound lessons where I would learn about the underlying causality of disease and see these native populations where they had obvious nutritional disease, like the Indians people. They really aren't supposed to eat our foods, so it became very, very obvious to me that a lot of their diseases was coming from nutritional factors. And then working in Micronesia, you see the exact same thing where these people living on these islands where they're eating natural foods, and you have a Micronesian person eating pandanus fruit and tuna and giant clam. They're fine and have no disease, and as soon as they start eating Coca-Cola and sun chips, they have profound disease, including infections and cardiovascular disease and cancer. So some of those experiences made it very obvious to me that we were dealing with nutritional disease on a larger scale in America, just not recognize it as such.
Wow. Well, I guess some of your background alludes to kind of how we met. You and I both applied for a job doing concierge medicine in Vail, which...
That's exactly correct.
We had a passion for snowboarding, myself skiing for yourself. And while we were out there, we obviously shared some common interests in, I think, integrative and functional medicine, and had many conversations on those topics.
Absolutely.
One of the things that I know we did address was the topic of andropause as related to metabolic syndrome, as related to chronic fatigue, as related to sort of global dysfunction as we age. And a lot of the folks we cared for, even though they came from a reasonable socioeconomic background, they struggled with the same things everyone else does, and that's gaining weight as they got older,
sure.
Loss of energy, loss of sexual desire, and ultimately loss of function. You want to talk a little bit about how that blew up into a practice for you? Because I know you and I went our separate ways after that as far as practices went. One of our colleagues, unfortunately, was killed in the business moved to another owner. Tell me a little bit about how that evolved for you once you left Vail.
Yeah, I think where we should really go back to that is the kind of the larger story. And the larger story is kind of misunderstood, I think, by the great number of clinicians in the United States, which is that everybody perceives this concept of andropause as being a normal effect of the aging process in the United States, and that's really not true. when you actually look back at the data, and the best data that actually comes out of that came out of a study from New England, starting back in the 1940s, is that the average man in the 1940s had a testosterone level that peaked around 1,000 or 1,200 when he was 25, 30 years old, and actually would decline to a level of around 700 to 750 before he would naturally expire at age 74, an average age of around 74 years old. And the interesting part of that is that over each decade, when they repeat this study, there's a decline in testosterone in the entire population. And in my practice, I take care of a lot of people who have low testosterone levels. The only people who actually meet those idealized historical norms in general are the older folks. So in my practice, when I have people coming into my facility, and there might be a little selection bias here, but I see, a 75-year-old guy with a testosterone of 700, 800, and with a fair regularity. My average guy coming in has a testosterone, say 35, 40-year-old guy, about 300, 350, which is about 1/2 to 1/3 of what the historical number should be. And the reasons for that, I think, are fairly intriguing, and nobody really knows. It could easily be some of the diets we have in our lives. It could be some of the stress. It could be electromagnetic radiation. But the predominant theory is that there are all these xenoestrogenic compounds that are actually found in our foods sources. And they're everywhere to the point where they're absolutely unavoidable. And after World War II ended, in the 1940s, the bomb factories closed down. They started taking all the bomb factories and all these different, people who were unemployed and started creating these new factories. They started creating personal care products. And the personal care products very frequently used petroleum byproducts like phthalates that are now found in almost 100% of soaps and shampoos that are in the area. And when you actually look at somebody's body and you start looking at the level of these chemicals, if you do a simple little biopsy of somebody's skin and put it under a mass spectrometer, you can usually find 250, 300 different industrial chemicals, many of which are either direct xenoestrogenic compounds, meaning they actually interact directly with the receptors in your body, or there's another little enzyme in your fat cells that actually is called aromatase, and they actually inhibit the aromatase, or change the way the aromatase functions and actually increase the conversion of testosterone to estrogen. And then once you get the high levels of estrogen, the estrogen is read by the little receptor in your brain called the hypothalamus, which actually looks at the levels and then will inhibit other hormones in your body, the luteinizing hormone and follicle stimulating hormone, which reduce testosterone. So either directly from the xenoestrogenic compounds interacting with your brain, or through high levels of this estrogen in your body called estradiol, people's regulatory apparatus reduces and then their body makes less testosterone. And we see that in younger and younger and younger ages.
Wow. So what you're sharing with us now is the fact that basically environmental poisons and exposures to these xenoestrogens are leading men specifically into these states of andropause way prematurely.
Exactly.
Okay. So
which is why I reject the term andropause. It
Sure.
insinuates that it's a natural process.
Natural process.
And every indication is this is not a natural process.
So,
and when it's a 30-year-old guy, you can't call that andropause, right? This is not a normal process.
Sure. So you're saying that this is sort of a disease brought on by the environment, and that this is, what is it? Is it a form just of hypogonadism secondary to the false feedback that the brain's getting from these?
That's exactly right.
Okay.
Every indication is that that's exactly what's happening. Okay. And the second part of that is people start eating less and less nutritious foods, eating more processed foods, more simple grains. They don't have the complex chemicals in their diet that they need, the methylation groups and other nutrients that lead to hepatic detoxification of these fat-soluble xenoestrogenic compounds. So they tend to build up higher. So when we're trying to take somebody who regenerate their hormones in their body, one of the things we concentrate on is actual nutrient sources, because that actually helps them to detoxify and remove some of these xenoestrogenic compounds from our body. So it's a combination of both the poor American diet, where we have calorie dense and nutrient poor foods, which inhibits detoxification, and then on top of that you have this overabundance of these xenoestrogenic compounds, sometimes natural but typically artificial chemicals that seem to be causing this to become endemic a massive pandemic across the entire United States.
Wow. Well, for our listeners and viewers, can you talk a little bit about some of the hormones that are at play? I think a lot of people just think in the man it's simply just testosterone, in the woman it's just simply estrogen or one of the estrogens. Can you talk a little bit about the interplay between these hormones and how people generally feel? I mean, most people are like, wow, if I'm in my 50s, I want to strive to feel like I was when I was 21, 22. So talk about what happens not only with these hormones but over time.
Yeah, that's a great point. So, I think one of the things that people don't realize is that there's an entire cascade of hormone synthesis that happens in the sex hormones in the human body. I wish we had a diagram that we can show this on, but basically you go from cholesterol, and then the first relevant, hormone people start, that breaks down into is called pregnenolone. Pregnenolone is very, very frequently extraordinarily low, again, probably from the presence of different chemicals that interrupt the normal synthesis of these compounds in our body. And people who have low pregnenolone levels will usually have higher levels of anxiety, maybe a little depression, maybe a little problems with mental recall, sometimes a little bit of fatigue. Pregnenolone kind of becomes the master hormone, and then pregnenolone will break down either down one pathway into progesterone, which gives people kind of a little bit of energy, a little bit of feelings of comfort, a little bit of kind of executive function. That will form into cortisol. So that's one pathway. People with low cortisol will usually have kind of low blood pressure. They'll feel frustrated, sometimes low energy, sometimes have problems with weight and weight loss. So you can have problems anywhere in these cascades. And when you get on the other pathway, you form into DHEA. DHEA is another one of the anabolic hormones. Gives people, again, a little bit of energy, kind of helps them with stimulate their immune system. DHEA will actually break down into testosterone, which of things is the course of the hormone that most people are aware about the most. And testosterone, is kind of misunderstood. People really think it's an aggressive hormone or it's an anabolic hormone. If you had to break it down into one thing that it gives most people, it's really confidence. And that would be sexual confidence to initiate a sexual encounter. That would be confidence to stick up for yourself in a public setting. That would be the confidence to take on a new task. And really, when you start looking at hypogonadism, that lack of confidence is one of the things that most people complain about. And then testosterone directly breaks down into estrogen. Estrogen for men is every bit as important as it is for women. And you need the estrogen, number one, because it provides people a little bit of that kind of comforting molecule, but it also increases the elasticity in what we call the compliance of their connective tissues in their body. And this is something you run into when you start taking care of a lot of bodybuilders, is they start taking really high doses of estrogen blockers. And when you block that estrogen because you're trying to maximize your testosterone levels and maximize your anabolic drive, you actually lose the compliance, the elasticity in the connective tissues to the point where these guys' muscles will get so strong they will literally tear the tendons and the ligaments off their bones and their muscles. It even gets to the point where at least one person I know probably resulted in his death because he completely suppressed his estrogens to the point where he had an aneurysm in his brain, and it might have played a role in the fact that it was leaking. He was taking massive overdoses of testosterone and blocking every last little bit of his estrogen. And within about a year or two of doing that, he died from a cerebral hemorrhage.
Wow. I think that you touch on that point, and it's critical to know that when people are supplementing or replacing or augmenting somehow these levels of hormones, we're doing it to sort of a physiologic level, not to a super physiologic level, which is a lot of times what you see within the bodybuilding communities or the powerlifting communities who are using these drugs for enhanced performance. So talk a little bit about the healthy ranges for a man, and maybe talk about several age groups.
Sure. This becomes very germane right now because there's been all this controversy over testosterone supplementation, with some data coming out that you actually are getting a little bit of increased risk of cardiovascular disease. And there might actually be some relevance to that if you're not looking at it correctly. So as you talked about, super physiological levels and physiological levels. So a bunch of studies were done a couple of years ago to find out what is the best level of testosterone that any individual can have. And mortality seems to be lowest right around a level of around 800. So when I'm taking care of somebody, what I'm really looking for is a physiological level of around 800. I never want to go higher, and I don't really want to go lower. We kind of want to get people right to that 800 level. Bodybuilders, of course, use extraordinarily high amounts trying to push themselves into a very strong anabolic drive and create large muscle mass. And for a whole bunch of different reasons, a lot of physicians, when they treat, will try to push that past that 800 level because men initially will actually feel better. Now, that's the important differentiation there. initially. Once you kind of push past the 800 to 1,000 level, just like any other time in your body is smarter than you are. If you constantly run your body with very high testosterone levels, you change the number and the density of receptors on your cell, and your body starts going into this period where it adapts to it, and you get less and less of a physiological response to the same levels of testosterone. So when you constantly run high, initially people feel awesome. They have great libido, they have huge confidence, they have good athletic performance. And then if they do that intermittently, it's kind of like they can get away with it. But if you stay too high for too long, you start to lose the effect. And when you do that, people then want more and more and more testosterone. It's just like somebody who's addicted to opiates who takes larger and larger and larger amounts. You can be absolutely become addicted or habituated to excess amounts of testosterone. One of the problems that we run into is that the testing that we use for testosterone is very frequently erroneous. So, for example, if you are giving yourself an injection, when you inject that testosterone into your muscle, it actually is picked up, and part of that testosterone starts to ride on the surface of the red blood cell and is picked up by albumin and other formed elements within the blood. So then you do a venipuncture, you pull the blood out, you then spin it, you lose all the formed elements. So 20 to 30% of the testosterone that you inject into somebody, this is very general, it varies dramatically between people, but in general about 20 to 30% will actually be in the red blood cell membrane. So when you're testing somebody, if they have a serum level of say 1,000, really they have a level of around 1,500. So it becomes dramatically elevated. Now, that's not so bad, right? That's only a small margin, 30%, 40%, 50% different, no big deal. But it really runs into problems when you start using topicals. And there's a bunch of different patches, and there's a bunch of different, on an armpit, gels. And sometimes people make, compounded creams, and I make compounded creams as well. But when you do that, you hardly see any of that testosterone come through in the serum at all. So when you rub a little bit of the cream on your body, the first thing that cream does is going through your skin and goes through the stratum corneum, starts going into the capillary beds, and the little red blood cells are being squeezed through the capillary beds, is that testosterone rides almost entirely on the surface of the red blood cell membrane. So once again, when you perform the venipuncture and you actually want to go ahead and check the levels, you spin it down the centrifuge, you're losing about 80% of it. So you only see 20%. So what I do when I manage one of these clients is I take their baseline testosterone level, say it was 400. We're trying to get them to 800. So you want to go up by 400. So you're going to basically be happy with an elevation in their blood by about 80 to 100 points.
Okay. But with that point you just stated, my question would be is, are they not of physiologically normal range? If is this a carrier issue at the physiologic state? In other words, are red blood cells attaching to or binding to the testosterone that's in circulation? So does that make sense? Like, so if you get a 50-year-old with a blood level of 400,
so
is it truly
endogenous
600?
Production released from your testicles,
unaffected.
Okay. It's only the artificial supplementation
that
changes the tissues and where the testosterone is actually going to hide within the body.
Okay.
So when you're doing serum levels, you'll see these egregiously inaccurate levels. So if you titrate somebody to say 1,000, which is what my physician did for me when I first got on supplementation of testosterone as a cream, my actual physiological serum levels were closer to 4,000 or 5,000. And I was able to do that by looking at multiple different modalities. So you can actually see how much testosterone is being delivered to, say, your tissues by looking at your saliva. So if you spit in a tube and you are putting on that much cream, you'll actually see 400 to 500% elevations in your testosterone above normal levels. Another way to do it is actually do whole blood, and you do that through capillary testing. One of the companies that does that is ZRT. You actually poke a little hole in your finger, and then you're getting whole blood analysis. You're getting the red blood cells, you're getting your albumin, you're getting your serum proteins, and you're getting your serum, and you can look at that, and your levels might be 400, 500% elevated above what they are. So when you start doing these, kind of fancier testing modalities, you can see that elevation. But if you're relying simply on serum, very frequently you're going to have a massive overabundance of testosterone. People will be treated.
What would you say is the general approach for most clinicians out there treating, hypogonadism or low T? Was it blood draws?
95, 98, 99%, absolutely.
So you could be technically stating that we're over-treating all these patients.
In my opinion, 98% of men who are giving testosterone supplementation are overtreated. Yeah.
Okay.
I think it might be that high.
So in the long-term sequelae,
and that's one of the reasons now there's a backlash against it, is because there's nothing intrinsically wrong with testosterone. We know when testosterone is too low and you raise levels to normal levels, you're actually going to reduce cardiovascular mortality. But what's going on, and when I read these studies that are produced by the pharmaceutical, companies, they are doing them inaccurately. They're doing them through blood sample testing. They're almost always over-treating people. And yes, when you're taking a dramatic overabundance of testosterone, then you are going to increase cardiovascular mortality. Additionally, so if you're getting into the finer points of managing somebody's testosterone, you not only need to look at the testosterone levels, but you need to look at the conversion to estrogens. And when people's bodies are overwhelmed, or they're sicker, or there's other chemicals involved, you'll actually get a degradation of your testosterone into estradiol. So you really want to maintain that somewhere around a 15 or 20 to 1 ratio, and you want to get that level right. You can stop the conversion with natural substances like simple as zinc. You can do things like chrysin. You can do things with stinging nettles. Sometimes use a little estrogen blocker like anastrozole, which would be a prescription medication. But you can actually fine-tune and manage that. And when you do that and you manage the right levels, you get the good vascular compliance, you get the protective effects of the estrogens, and then you get the benefits of the testosterone. But when you just give somebody a massive overabundance of testosterone, sometimes you actually are dramatically spiking up their estradiol levels as well. And we know that, too high of an estradiol level is actually a risk factor for cardiovascular disease as well, as far as a thrombotic event, a blood clotting event.
So you bring up some good points. So there's some other natural supplements that could potentially be given to interrupt conversion of testosterone to estrogen, and thus so doing rebalancing, number one, but number two is potentially bumping up those pools of testosterone. So is there's possibly a way that, say, somebody who's 39, 40 years old who has low T could be on a natural substance to get that to shift in their favor?
Yeah, without a doubt. So, one of the things I always look for when I do somebody's evaluation, and most people walk in my office who've been evaluated elsewhere, they'll have a testosterone level. If the doctor's being real fancy, they'll do a free testosterone level. And really to do it, you need your DHEA, you need your testosterone, you need your estradiol, and sometimes it even helps to get estrogen metabolites, which can't be done through serum. They really need to be done through urine. But what you're looking at is you're actually looking at trying to find the balance of each of the different things. And in general, these are very generalized kind of numbers. When somebody gets an estradiol level over around 35 or 40, there's a reasonable chance that that estrogen is going to come around to the hypothalamus, be picked up, and is going to suppress the luteinizing hormone and follicle-stimulating hormone that are going to make your testicles release higher levels of testosterone. So we call that negative feedback inhibition of the hypothalamic pituitary axis. And in those people, if you can simply bring their estrogen levels down, you actually can raise their testosterone levels back up. So I might have somebody who has full-on, complete hypogonadism. Really, that is defined as a testosterone of around 200. When your testicles are no longer producing testosterone, your adrenal glands will kick in at like a stress dose amount. They'll make about 180, 220. So you'll have zero luteinizing hormone, zero follicle-stimulating hormone, and a serum level of around 200. And unless somebody's on a pharmaceutical or something's really wrong, usually you're not going to get less than that 200 level. So if you take somebody like that and they have an estrogen of, say, 60, 70, 80, which is fairly common, and you bring that level from 60, 70, 80 down to 20 or 30, which is still a fairly healthy level, a lot of times what you'll see is the luteinizing hormone and the follicle-stimulating hormone be released from the hypothalamic pituitary axis, and then their testosterone will actually come back up on its own.
Okay, great.
And that's a pretty cool way to do that. Occasionally, the reason the estradiol is too high is because people have certain genetic deficiencies in their ability to break down the estradiol. So it's just something like the catechol-methyltransferase gene, where they just can't break it down. And in those people, rather than using something like an inhibitor, you can actually use like acetyl-methionine, SAMe. And SAMe is the methyl donor for the breakdown of estrogen in the liver, and when you give that SAMe to somebody with the catechol-methyltransferase gene, you can actually get their body to eliminate it on its own and get rid of not only the estradiol, but all the secondary estrogen metabolites, which also can suppress the hypothalamic pituitary axis function. So you can see that pretty easily if you look at somebody's hormone metabolites, and if they have a normal catechol-methyltransferase gene, they'll make a lot of like 2-hydroxyestrone, but they won't make any 2-methylestrone because you need it for the secondary pathway. So estrone breaks down into 2-hydroxyestrone, which then breaks into 2-methoxyestrone, and then methoxyestrone won't happen if there's a catechol-methyltransferase gene. You can also do a genetic test looking for the exact same thing, but the estrogen metabolites for most people are usually easier. So as soon as you see that, if you give large doses of SAMe, 200, 400, 600, sometimes even 800 milligrams a day, you'll actually see these people break down their estrogen metabolites. They'll start dropping their estradiols, and then frequently, not always, but very frequently, you'll actually see them start kicking back in and making their own testosterone again.
Wow, that's fantastic. So talk to me a little bit about that's certainly one pathway. Talk to me a little bit about the role of things like HCG and Clomid for some of these clients.
So it's kind of breaking it down into the into the causality, right? There's a certain subject of people, subset, that has the very high levels of estradiol. And then there's other people who have total suppression, right? They have zero luteinizing hormone, zero follicle-stimulating hormone. You can't see any estradiol in their body. You can't see any elevated estrogen metabolites, yet they still have secondary hypogonadism, meaning that they have no drive. Their body's not asking their testicles to produce hormones. They don't have any LH and FSH. So the question would be why? Well, these are the people that I kind of, consider to be the xenoestrogenic compounds, the people who have poor detoxification mechanisms. And in my clinic, I'm afforded the luxury of sometimes being able to go and doing like full exome analysis and seeing all their detoxification pathways. And it's pretty interesting to see that because you see the genes that are associated with the detoxification, and you can actually sometimes get it down to the exact nutrients and exact things that they need to bring them out. But in general, we don't have that ability. So when you have secondary hypogonadism in a patient without high estradiol levels, you realize that you're getting, in more likely than not, these xenoestrogenic compounds, which are inhibiting the release of the luteinizing hormone, follicle-stimulating hormone. You have two options. You can either undergo a long-term, prolonged, multimodality detoxification regimen and do genetic testing to figure it out, or you can simply try to get the body to reinvigorate the hypothalamic pituitary axis, and you do that with these drugs that work on the hypothalamus. The two most common ones that are used are either HCG, human choriogonadotropic hormone, or an old school drug called Clomid or clomiphene, which is used predominantly in women to try to get them to ovulate. So I think one of the things we were talking about before is that the role of these different hormones, right? Men have testosterone and estrogen just like women have testosterone and estrogen. We all have the exact same systems. So a fertility drug given to a woman is going to affect men very, very similarly. So when you're given this Clomid, it basically blocks the effect of all of the xenoestrogenic compounds on the hypothalamus, and then your body will respond by raising levels of luteinizing hormone and follicle-stimulating hormone and actually regenerate your testicles to start making not only testosterone but sperm as well. In guys who've had long-term secondary hypogonadism, they often experience testicular atrophy. And when you give somebody the right dose and this therapy actually works, sometimes they actually feel like they get kicked in the testicles, and we call that ripening of the fruit. Their testicles will literally feel tender for a couple days, and when people measure them, actually will go up 30%, 40%, even 50% in volume over a few weeks or a few months.
Talk to me about some of the doses of HCG, because HCG has been touted as a weight loss hormone at lower doses. Talk to me about the kind of doses you'd be using for somebody with hypogonadism.
So I certainly don't want to be anybody's physician to give bad medical advice and give too much. So this is something everybody needs to discuss with their own practitioner, and there are multiple protocols. Most of the literature recommends somewhere in the vicinity of similar to weight loss doses, 450 international units 3 times a week, 600 international units 3 times a week is fairly typical. It's a decent place to start. Sometimes people require a little more aggressively to kind of get things going when they've been suppressed for a long time. But that's pretty typical.
Back in the 80s, you'd hear in the locker room talks about people coming off gear, and
Yeah.
that their goal was to reset things. And
Absolutely.
HCG obviously was one of those drugs, and I know some of the doses that you talked about are right in the ballpark of what they've talked about in the past. Talk to me a little bit about why you would prefer to do this versus direct supplementation with testosterone.
Sure.
Because a lot of doctors just go right to the testosterone.
Exactly. So I don't mind sharing the fact that one of the reasons I got interested in this myself is that I started getting exposed to a bunch of chemicals at one point in my life. I was actually working on boats. I was rebuilding a boat and working with a large amount of epoxy. I don't know if you know the history of epoxy, but the first female hormone ever produced was actually BPA. They intended for it to be a hormonal therapy for women. And when they tried to make it into a pill, it polymerized, turned into a plastic. So they saw an opportunity here, and they actually turned this female hormone into plastic. And the epoxy that we actually use today, and the inside lining of every one of our little coffee cans and soda cans, is actually epoxy, which is one of the most potent xenoestrogenic compounds ever created. So I decided to build my boat, of course, out of epoxy, not knowing any different. And I'd be out there sanding it and getting epoxy up down my arms and taking acetone rags and wiping it off and
pushing it into your body.
dramatically overwhelmed my body with huge doses of BPA. Can we get really silly here and start talking about all the good things that happened to me?
Yeah, no, talking because this is serious.
So no, it is serious.
Patients are going through this as we speak.
Sure,
Yeah.
and I don't mind. I tell everybody this, so I might as well tell the public. During that period of time, I started getting hot flashes. Literally having hot flashes. Not to be disparaging to anybody, but I was working as an ER physician in a high acuity urgent care center as well. And when people would start telling me their story, I'd start weeping and almost crying for them, becoming massively overly emotional. That went on for a little while, and then I just had really low energy levels, started feeling miserable. And then, I shouldn't say this online, but I will. I actually started growing breasts. I tried to go surfing for the day, and my breasts became sore. And I actually started getting breast tissue, and I could feel it underneath, and I couldn't even lay down on my surfboard anymore and go surfing, which was really kind of disparaging. So I became concerned maybe I had cancer. I'd seen a couple cases of cancer in men in the past, so I went down and I got myself I called a manogram and got evaluated, and of course there's no cancer there. And that was the point in time when my kind of career started shifting, and I'm kind of going, what's going on here? What's happening to my body? And I started trying to do a little research, and I realized that I just didn't know everything I needed to know about being a physician anymore, and started trying to figure out what was going on with me. Then I checked my hormones, and I had checked them about 2 years before. My testosterone was totally normal. Now I know much higher than it would have been for a normal person, 700, 800, which is higher than your average, say, 35-year-old guy, which is about how old I was back then. And now I checked them again. My testosterone was down to 170, and my estradiol levels were over 80. And it was so bad that I was literally growing breasts. My luteinizing hormone and follicle stimulating hormone had crashed to almost nothing. And I was in complete and total, hypogonadism.
So who did you go to at that point in time? Obviously, you knew there was a problem.
So yeah, at this point in time, I was a dyed-in-the-wool regular physician, wearing my little white coat and my little tie. And I went to an endocrinologist. And I don't want to go into that, but it was an absolute waste of my time. He didn't give me any of the answers I wanted, and he just tried to put me on testosterone replacement therapy. And then I actually went to a functional medicine physician. And it was a guy that I'd seen a bunch of his clients in, seemed to really know what he was doing. And I thought he would be an expert. And rather than offer me injectable therapy, he offered me a cream. And I didn't know any better at the time, so I agreed to it. And he gave me a dose which is 500% the dose I give now. But I didn't know any better, so I started using it, and I felt awesome.
Right. How long did that last?
For 6 months or a year, I felt awesome. I feel bad for my poor wife because she didn't get left alone very much. And I'd walk down the street, and I'd try to, imagine whose ass I was going to kick next. And my libido was just off the charts. And for 6 months or a year, I felt awesome. And then after that, one of the reasons I do this, and I'm passionate about it, because I've been through all this stuff myself, I started to lose the effect of it, and I started asking him for more, and the doctor who was giving it to me wouldn't give me any more. And that's when I started checking my levels. There were 1,200 in my serum, and I thought maybe that those numbers weren't high enough because I wasn't feeling good anymore. I didn't realize I was undergoing this process we call tachyphylaxis, becoming, essentially addicted to the drug, habituated to the drug. So then I started checking my serum levels or my blood spot tests. When I did my blood spot, I convinced myself that I actually had contaminated my specimen sometime by testosterone in my finger because the levels were coming back 500, 600% normal what they should have been. And then I started doing my saliva tests, and they would come back 500, 600% normal. And this is one of the reasons I started realizing that all this stuff was going on. Eventually, I came to the conclusion that what I needed to do was to completely stop all testosterone therapy, which I did, and I knew there was no chance at all I was going to regenerate my system until I had a long break to let the receptors come down in my brain and my neurological tissue. And then after doing that for about a year, I started then using pulsatile therapy with HCG and clomiphene, and finally got my testosterone back to where now. And at the time, I don't mind telling you, my testicles shriveled up to about half the normal size, and I could ejaculate. I'm sorry, I could have an orgasm, but when I did, almost no semen would come out at all. It was basically fully suppressed. Yeah. So my ejaculatory volumes went down. My testicles started to shrivel up. Took me about 2.5 years to recover from that. And now I got to the point where my testosterone levels are almost uniformly 600 to 700 is about where I run. And I feel totally comfortable with that level. It's totally adequate for me. When they get a little low, I can actually hear it. I hear, and it's amazing, my wife can't even hear this, but I actually hear a change in the timbre of my voice. And when I hear that change in the timbre of my voice, I take a little extra, a little clomiphene or a little HCG to kind of pop it up, and I just watch my diet a little closer, take some more of the supplements, a little zinc, sometimes a little bit of chrysin, and I can kind of just get back on board.
Great.
So that's what I do. And in that period of time, I started taking care of a lot of people in the Florida kind of bodybuilding scene, who goes back to your point about the post-cycle therapy. So a lot of these guys who've been, using large amounts of testosterone or anabolic steroids for years, that completely and totally suppressed their systems, and now we're getting a little older. They didn't want to take, the hormones anymore. They felt terrible off of them. They didn't want to be on anabolic steroids. They started coming in to see me, with the intention of, completely getting off testosterone and sometimes even having children and families. So I became a little more versed in dealing with these issues because working with that population.
Sure. Well, you know what? We're kind of coming to the end of our time here on this topic. I want to know if you could do us a favor and sort of give us a 30,000-foot overview of, one, hypogonadism, and if a man out there listening to this thinks that's what he's going through or suffering from, kind of what are the first initial steps? What sort of lab should he be getting?
Sure.
And what sort of replacement therapies are reasonable to start off with and then ultimately with full-on replacement?
So I think one of the primary differentiators that isn't done when somebody comes to my office to be evaluated is nobody's actually done the very simple assessment to find out if it's primary or secondary hypogonadism. If you actually go back and read articles from the 60s, almost every client who is a hypogonadism patient had primary, which means that your testicles are getting too old and they're atrophying and can no longer make testosterone. If that's what's going on with somebody, their only reasonable option is to go under testosterone replacement therapy. And if they're going to undergo testosterone replacement therapy, it's totally safe. You just have to be moderate about it. So, a good baseline is, 40, 50 milligrams a week of testosterone cypionate. Just gives you a little extra boost, puts you in the normal levels. Once people start getting up, which they typically do, to 80, 100 milligrams, is just too much. Over time, what's going to happen is you're going to suffer from this negative feedback, issues, and you're gonna become resistant to the effects of the testosterone. So that's the primary differentiation. The differentiation there is simply doing the two tests. So you want to do a testosterone at the minimum. You want to do an estradiol. You want to check a luteinizing hormone and a follicle-stimulating hormone. If your luteinizing hormone and follicle-stimulating hormone are elevated, 6, 8, 10, 12, and your levels of testosterone are too low, well, that's primary hypogonadism. Your testicles just can't function. If you then do an evaluation on somebody and they have an extraordinarily low LH and FSH, maybe less than 2 or 1 or 0, that person clearly has secondary hypogonadism. The problem is not their testicle. The problem is that the brain, the hypothalamic pituitary axis, is not properly engaging the testicles, trying to get them to produce testosterone. And those are the people who really should be considered with Clomid, HCG, or estrogen elimination therapies in order to kind of revamp themselves. And by doing that, you can maintain fertility, potentially. You can get in good endogenous levels. You can avoid testicular atrophy. You can continue to ejaculate normally, and have a much better, long-term, clinical course. Whereas if you go directly to testosterone therapy, testicular atrophy, lack of ability to ejaculate, impossible infertility are all possible consequences from down the road.
Great. So I know we've talked about a wide variety of things, and I'm sure it's of great interest to the folks who are listening. There's something that I encountered in my clinical practice with the use of low-dose naltrexone.
Sure.
Is that some folks who are hypogonadal and are suffering from either ED or loss of libido.
Sure.
I give them LDN for other things, including autoimmune disease, if they have cancer. But their feedback is, hey, doc, ever since I titrated up on my low-dose naltrexone, I'm getting like morning erections. I have better libido.
That's
feel
awesome.
better. So kind of talk to me a little bit about that, because that's sort of...
Do you know why that is?
Well, I have some concept, but I wanted to talk to you about it because I know your experience in this is far greater, as to what's the mechanism for number one, and number two is, have you seen this in your practice?
I've seen it in my own. I didn't want to get into this. I didn't know we were going to get into this the autoimmune component of it.
Sure.
But low-dose naltrexone, of course, is a drug that it blocks endorphins. And as it blocks endorphins, it basically tricks your body making much higher levels of endorphins. And higher levels of endorphins do a couple things, and it basically works as a modulator for the immune system. It actually knocks down autoimmunity and reduces neurological inflammation. And in that regard, it's one of the most amazing drugs. And I would love to do an entire podcast with you on nothing but low-dose naltrexone, because I probably have 100 or 200 clients on it. But if you remember from medical school, autoimmune polyendocrine syndromes, some of those autoimmune polyendocrine syndromes actually attack the hypothalamus and actually cause neurological inflammation. So, you might get, autoimmune polyendocrine syndrome type 2, relatively common. You might get a little Hashimoto's thyroiditis, maybe a little rheumatoid arthritis. You might get a little Addison's disease. And then as part of that, you can actually get this inflammation of the hypothalamic pituitary axis. And I've never seen a study on it, but I guarantee you that's what you're seeing, and that's what I've seen myself. And in people we put it on, we often get rid of the inflammation in the hypothalamic pituitary axis. You actually re-engage the normal system, and you'll actually get, visible increases in luteinizing hormone and follicle-stimulating hormone. So when there's a suggestion or a clinical concern about a possible role of autoimmunity, then it's one of the things that I actually try to talk to the patient about getting on as well. There also, in some cases, might be a little bit of autoimmune attack against the gonad themselves, against the actual testicle, and you might attenuate some of that attack as well. But I think largely this is a centralized phenomenon which actually is protecting and restoring the normal function of the hypothalamic pituitary axis. So I'm glad you recognize that, because it's something I've recognized also for quite a long time.
My patients recognized it, that's for sure. And so,
but
putting two and two together.
Do these people have other autoimmune diseases?
Some do, some do, and some are dealing with the sequelae of either immunotherapy or
neurological inflammatory.
and then dealing with cancer themselves by trying to use it for immune.
The argument could also be made that there's probably most people have some level of autoimmunity. The question is how much.
Yeah. Oh, absolutely. And living in the environment we are, where we're exposed to so many things in our immune systems, like WTF, what am I responding to? And ultimately, when it starts to attack the body, we have problems. And I think LDN is something that probably is underutilized in the clinical setting, for sure.
Without a doubt. I don't know if you're aware, I think Pfizer is actually working on creating the left enantiomer compound of the naltrexone.
Interesting.
So this wonderful drug that we've all been using now for years and years and years is eventually brought back to the market as the newest, greatest whiz-bang drug on the market, and they'll charge 50 times more for it.
Right.
But
nothing
at least it'll increase the awareness of it.
Right, absolutely. Which
would
be critical.
So it's actually being studied by major pharmaceutical companies right now, and they appear to be recognize the utility of it, just like we do.
Great. Well, Jamie, listen, thank you so much for joining us here.
No problem. It's been great talking with you.
And I'm going to have you back, and we're going to talk about some other fascinating stuff as it comes to medicine.
All right.
Anyway, I'm Dr. Sean Devlin. I'm here with Dr. Jamie Raniolo.
Nice to meet you guys.
And we are going to sign off today from the Medicine Wheel. Namaste, and we'll see you soon. Take care.
The Medicine Wheel encourages all of our listeners to subscribe to our newsletter and podcasts as we continue to explore the world of medicine, bringing you up-to-date health and science information. The Medicine Wheel invites our listeners to email us any newsworthy stories or topics they wish to explore further and discuss on the podcast. For more information about the Medicine Wheel, please visit us at our website, www.themedicinewheel.org, and on Facebook, and finally on Twitter and Instagram at The MedWheel.
In an effort to support access to integrative medicine and functional medicine options for those in need and education for those who need information, please consider donating to Project OmCare, 501c3.org. Please go to our website, www.themedicinewheel.org, to learn more.
Thank you again to all our local sponsors, Grateful Gardens, Lighthouse Coffee, and Dorinda's Chocolates, which represent some of the best organic and appetizing options in the Reno, Tahoe area.
Lighthouse Coffee Shop is a proud sponsor of the Medicine Wheel. We are a family-owned and operated local coffee shop. Our goal as a business and a family is to cultivate community wherever we are. All of our coffee is ethically sourced, organic, and farm fresh. It's roasted in-house daily, guaranteeing you access to the freshest cup of coffee on the planet. We care deeply for our community and everyone in it. We strive to provide you with the best ingredients and most comfortable environment. Come and enjoy coffee with us. We are family, and we would love for you to be part of it.
Gerber Medical Clinic is proud to support the Medicine Wheel and medical education to improve health quality, nurturing the lifestyles of our listening community, enhancing wellness for all. Thanks again to Wired Insights and their talented team for making our podcasting dream possible.
In closing, we would like to remind all of our listeners, if you have a medical concern or diagnosis, you need to see your personal doctor without delay, and if needed, obtain a referral to a specialist. If ever you feel the health issue you have is urgent or an emergency, please call 911 and go to your nearest emergency room. Please do not take any of our physicians' commentary or our guests' opinion as medical advice, and always seek out medical care from fully licensed and appropriately trained medical professionals in your area. The information shared in this podcast is for general information only and should not be construed as medical advice, and understand that no doctor-patient relationship is formed. The use of this information and educational materials linked to this podcast and website are employed at the user's own risk. The content of this podcast is not meant to be used as a substitute for medical advice, diagnosis, or treatment.
This is the Medicine Wheel signing off for this week with a reminder to live, love, listen, and learn.